Hematology-Oncology, and she has helped develop the program at Baylor at Houston Children's Hospital, and sees a lot of very complicated vascular lymphatic patients and presents them at our meetings for discussion.
Yes, I'll put it up. Thank you very much. So welcome, everybody. Good afternoon. Thank you so much for inviting us here. We always love to talk about lymphatic anomalies. And again, like all the presenters before me said, we wouldn't be here if it wouldn't be for you. So the fact that you are interested, you want to learn more about what's happening to you and how we can help with this whole discussion, it's actually the one advancing the field. So I'm a pediatric hematologist-oncologist, so I'm not going to go a lot in details of genetics and basic science. We're going to have dedicated talks for that. So I'm very clinically oriented. I'm face-to-face with the patient, and we have the families coming to us for diagnosis, for understanding the diagnosis, and then to try to find a solution for their child. So maybe 20 years ago, or even less than that, there was this. So I said about 20 years ago, there was like this big chapter, and everything more or less was lymphangiomatosis, and inside there was this group of patients that were a little bit different. They were the Gorham-Stout disease. So Gorham-Stout was described, I think, even before they realized there's like really a lymphangiomatosis chapter in total. But that's about all we had. And then through the next years, a lot of other acronyms came about. So now we have GLA, Generalized Lymphatic Anomaly. We have Kaposiform lymphangiomatosis and central conducting lymphatic anomaly. So basically what we try to do is to find patterns, to find in this group of patients that we all know have some problems with their lymphatics, not an easy problem, a complicated problem. Try to group them somehow, because figuring out what's common for them, we will know better where to look in their blood, in their gene, trying to understand exactly how can we identify what's the problem, what they are different within their own group. So the first thing that was very clear was they were not simple lymphatic malformation. So in a simple lymphatic malformation, as you've seen this, if you want the body with the lymphatic system, you have all of this, I like to call them rivers, right? So you have this channel, you have these rivers of lymphatic vessels. They have a very clear blueprint. So it was supposed to be this way, not more to the right, not more to the left, not more in the left leg or in the right leg. This is what was meant to be. And then something happens, and it can, be from a gene, can be from other reason, and you have this like error. You have a local problem, have a local abnormality, and the fluid over there doesn't drain where it's supposed to be. So it forms this little cysts, this little bubbles, this, if you want, swamp that doesn't drain, and it just stays there. So as long as it's somewhere outside of the mainstream, it may still be just a simple lymphatic malformation. And a simple lymphatic malformation, no matter how close it's going to be to a bone or a joint, no matter how big it's going to be, it's really usually not attacking the bone. It just stays what it is. It's a lymphatic malformation, and that's all. The problem is when you have more than that. So when you have this type of small cyst, macrocystic lymphatic malformation and something else, this is where you go into that complex lymphatic anomaly. So you may have holes in the bones, so bone lytic lesions. You may have accumulation of this fluid, either around the lungs or inside the abdomen, or you may lose the proteins in the stool. So something inside the abdomen is not absorbing all the lymph, it's not absorbing all the fatty acids that were supposed to be. So any presence of any of this, it's taking the patient from a diagnosis of a simple lymphatic malformation towards a complex lymphatic anomaly. And we are still within just lymphatic. There is a completely different class of if you want, complicated vascular anomalies that include venous and lymphatic, capillary lymphatic. So we're not there. This is just still purely lymphatic, but it's more than a simple lymphatic malformation. It attacks something else. And then once we found this in a patient, we try as much as possible to put them to fit him in one of these four, as much as we can. And not all the patients will fit these patterns, will fit this criteria, but we'll try to look a little bit and how we're trying to classify them. So I'm going to start with if you want, the last one that came along, and there's still a very big overlap in between all of them, and there is definitely not clear-cut saying, the CCLA it's from A to C, and then from C to E, it starts the GLA and so on. So it's a very big overlap in between them, but more or less, if you want, in a little bit of a simplistic way, again, you have the body, you have the lymphatic fluid, and then for whatever reason, here is a problem. So somewhere in the middle, somewhere on the thoracic duct, it doesn't drain normally. And if it doesn't drain normally, then you have a lot of fluid that accumulates before this obstruction. And it accumulates as an effusion, again, around the lungs or around or inside of the abdomen, or it can accumulate downstream like lymphedema. But usually, or almost always, this fluid is not supposed to be bloody. It's supposed to be just chylous or lymphatic. And the medical therapy may help in a lot of them, but this is, if you want, kind of a plumbing problem. You're missing the channel. Something is wrong. Either it's missing, or it's been cut off, or it's leaky. Something happens over there, but you don't have the mainstream river that works correctly. So everything I'm showing you are from the patients in the clinic. So if anybody recognizes their pictures, then there are no names, so we're not going to say where they're from, but they're all from our patients in the clinic. So basically, when we try to image that, all of this black is supposed to be the normal lymphatic dye, and you see that it's supposed to be a line. It's supposed to be a very simple line, and it doesn't look like that. It looks like it's leaking outside of it. And I'm not going to go into the imaging because we have very good presentations on it. But when you don't have, again, a very clear, straight direction of this lymphatic fluid, then you accumulate fluid around the lungs. So this is a CAT scan, a computer tomograph of a patient. That's the heart. And these lungs, they're supposed to go all the way down to the ribs, but they can't because they have all of this lymphatic fluid that accumulated over there. And this may be lymphedema that you can see. Now, Gorham-Stout disease, it's a little bit different. So in Gorham-Stout, for whatever reason, something happens, maybe a genetic anomaly or something else, and these lymphatic vessels start to attack the bones. And you have this uninhibited formation of new lymphatic vessel that would really go and destroy the bone. And it will be so aggressive that if you don't treat it, if you don't try to manage it somehow, they will completely destroy that area, the cortex, and it will go into the vanishing bone disease, into the Gorham-Stout. Again, there is a lot of overlap between all of this. I'm just trying to, as much as possible, simplify it and to put it into one bucket for all of them. So I'm not sure if you can see, but this is like a humerus from a patient. This is not affected by nothing. It's supposed to be white. If you look how many holes are in this one. So this is like really affected by the lymphatics. This patient was a teenager that was perfectly fine, absolutely no problem, football player, and had a chest x-ray for sports, everything amazing. Next year has a lot of chest pain, bounces between different facilities, and finally somebody gets a chest x-ray, and he's missing 5 ribs. So they're gone. They completely dissolved. So again, they were there. We know that he was born with them. It's just that the disease was extremely aggressive, and again, he had Gorham-Stout and had rib destruction. There was another one of our patient that had multiple fractures in the femur, so one of the big legs, big bones of the leg, and all of this white represents the, if you want, the lymphatic fluid and the aggressive lymphatics that are destroying the bone. He had fractures in this bone multiple times, and every time they were trying to fix it, you try to put a rod in it, you try to fix it in any possible way, it will just reject it and it will have more complications. So we started the medical therapy, and the bone is still crooked, right? None of my drugs will ever fix a bone to make it straight. But what it did, it kind of improved a lot of the lymphatics around it, and that, if you're on the black line around it, that's the cortex. So it made the cortex around it healthy enough so that the child was able to tolerate now surgical intervention. In generalized lymphatic anomaly, basically it's multifocal. Something happens not just in one bone. It doesn't happen just inside of the big thoracic duct. It's different areas of the body that are under attack. And you can have areas of macrocystic lymphatic malformation. You have multiple areas of bone destruction. But this bone destruction are just like if you're on tiny holes. They are not as vanishing bone disease. The bone is not going to be dissolved. It's just going to have a punch hole in it. And I think it's easy if I show you. So look at the scalp. You see all of this? Like somebody put a shotgun through that scalp. Like all of this black are small scalp lesions for this patient. You can have significant lymphedema, like it's in this baby's hand, and again, accumulation of all this fluid. So this is all ascites, so fluid within the peritoneum, and that's a lot of fluid around the heart in this child. And then Kaposiform lymphangiomatosis, like imagine everything I just told you a second ago for the GLA and add on top of it that the fluid is actually bloody, that you have a coagulopathy. And it's not only accumulating the effusion, but actually you bleed within it. And it's one of the most aggressive and one of the most difficult to manage of the four entities. So we're trying to understand it, again, a little bit more, and we're trying to study it and try to see how can we manage, how can we improve it. And again, from the clinical perspective, we're trying to look at what is it for this patient that makes them at risk for complications. And one thing that was in the literature for many times was the lymph loss, meaning that whenever you have the lymphatic fluid that doesn't go back into the main circulation, you lose a lot of fat, you lose protein, you lose immunoglobulins, you lose lymphocytes through it. So we're trying to look at patients from different lymphatic malformation, a different lymphatic diagnosis, and try to understand if we can make an easier differentiation between the entities. So this is from a grant that was funded by the Lymphatic Malformation Institute, so again with the help with LGDA, and we use the patient data coming from these resources, from this registry. So I really hope that everybody in this room participates in the registries, because this is how we can advance. I have a certain number of patients, Dr. Bly has a certain number of patients. If we only look at our small cohort, we'll never get to the big answer. So please participate in registry, because this is how we can get the results. And then we looked at 3 markers. We looked at the lymphocyte count, the albumin, and the immunoglobulin, and we had some very interesting results. And again, I'm not going to go through all of them. It's still in the preliminary analysis. But basically, about 27% of the patients in general had a low lymphocyte count through their life. 55% had normal lymphocyte count, and about 18% we don't know. The labs were never checked. So one other thing that was interesting was that even though the lymphopenia was frequently encountered, we found that in many patients, the odds of having lymphopenia was very similar with the patient with simple lymphatic malformation. So that was a bit different, because we thought that you lose a lot of this in the effusion. I mean, just logical, right? You have all of this amount of fluid, you lose it in there. But it's not only that. So the low lymphocyte count was very clearly associated with the effusion. So if you're on the higher risk of having low lymphocyte count if you have a diffusion, but it was not enough. So it was not a complete 100% overlap. That means that it's not just one factor. It's not only one thing that contributes to having a low lymphocyte count. It must be something else. So it may be also decreased production for whatever reason. That. And then again, we tried to look afterwards at the albumin. We tried to look at the immunoglobulin. I'm not sure you can see it, but when we looked at all of them, again, if we try to separate the CCLA, generalized lymphatic anomaly, Gorham, Kaposiform, the numbers are small. And the percentage of patients that have low lymphocyte count in CCLA, it's very similar with the one with simple lymphatic malformation, not a big deal. If you try to put them, all 4 of them together, all lymphangiomatosis together, and then compare it with simple lymphatic malformation, is a very clear difference. Try to separate them, didn't show much of a difference. Again, we're still trying to take out all the variables, and we'll probably have a better number at the end. But this is more or less the same with the albumin and with the immunoglobulin. What I'm trying also to show you through this is that we had in total 309 cases, 309 patients that we analyzed. We only had data in 240. So one thing that came very clearly through this is that even though patients may have similar disease, they are treated at different institutions, they are treated completely different, and not only the management is different, the way you monitor them is different. What do you check? You know, how do you look at a patient that has a suspected vascular anomaly? What type of studies do you do? So again, with the help of LGTA and LMI, 2 years ago in Atlanta, we had a large consensus meeting, and we separated into groups based on our specialty and tried to make, if you want, a list of how do we recommend a patient that has a complex lymphatic anomaly, how can we advise the local physician what to do, what studies to do. And then we went through the radiologic, through the blood work, and through the special functional studies. And then not only that, but again went into very, very detailed, okay, now you did an MRI, but what exactly do you need in that MRI? What sequence to have in the MRI? How to perform it? We are a referral center, so we have a lot of patients coming from all over US, and it's very hard to look at the imaging studies because some of them, they're missing elements that we need. So then you have to put the child again through another sedation. You have to ask the insurance to pay one more time for the missing information. So if everybody will have this available to say, these are the guidelines, please use them. You use this recommendation to analyze a child, and it would be much, much easier. So that's all I have. Thank you.